Good afternoon, everyone. My PhD topic is the effect of obesity on the progression and outcome of acute inflammatory diseases. My name is Dalma Köves-Dobszai, and my vision is aiding physicians in risk assessment and decision-making about obese patients. And to be able to do that, our mission is to comprehensively address all factors related to obesity for deeper understanding the way they interact with each other. We have already conducted a meta-analysis that investigated how body mass index correlates with severity and mortality in acute pancreatitis. And as a continuation of our earlier work, we took other obesity-related factors into consideration. And now we are investigating how metabolic syndrome factors affect the outcome of this disease. As my second project, I will be investigating these same 4 metabolic syndrome components, but in this case, on the outcome of COVID-19 infection, and we will do a cohort analysis. So please let me introduce my first project that is investigating the effect of metabolic syndrome on the outcome of acute pancreatitis. The mortality rate of acute pancreatitis can even reach 50% in the severe form of the disease, and as obesity rates are increasing, so does the prevalence of metabolic syndrome, especially in the Western countries. And earlier studies have shown that metabolic syndrome factors are associated with a more severe outcome in acute pancreatitis and even higher healthcare costs. It may seem like we have sufficient evidence in this field. However, these earlier studies were either meta-analyses with high heterogeneity and focusing on only one factor, or cohort studies with low sample sizes. So our aim is to now investigate the individual and synergistic effect of MET factors on the acute pancreatitis outcome in a comprehensive meta-analysis. Our clinical question was how metabolic syndrome factors affect the outcome of AP, and we investigated 4 exposures: obesity, diabetes mellitus, hypertension, hypertriglyceridemia, and we wanted to see how they affect mortality, disease severity, and the rate of complications. Our hypothesis was that metabolic syndrome worsens the outcome of acute pancreatitis. We have conducted a systematic search in 3 databases, and from almost 20,000 articles, we included 86 in our final analysis. We have finished the analysis for metabolic syndrome and 3 of the factors, but the rest of the analysis about obesity, including BMI, waist circumference, and visceral adipose tissue, is still ongoing. As you all know, one of the most important outcomes of acute pancreatitis is disease severity, which is mild if the patient does not develop any complications. It is moderately severe if the patient has developed some complications or an organ failure that resolves within 48 hours. And we talk about a severe disease if the patient has a persistent one or multi-organ failure. In our study, we have included both prospective and retrospective studies, and there is an overall high heterogeneity among the studies, which is partly due to the fact that the articles applied a slightly different definition for metabolic syndrome, and there is a huge difference in the number and the type of centers that the studies included. On our first forest plot, you can see that patients with metabolic syndrome have almost 40% increased risk for severe acute pancreatitis, and however this result is clinically relevant, it is not statistically significant. When comparing metabolic syndrome patients as regards mortality, as you can see, 2 of the studies showed an association between mortality and metabolic syndrome, and the other 2 did not. And the reason behind not getting an answer in this question is most probably because of the low number of events in each group. However, when investigating hypertension individually, we did find statistically significant differences, and we saw that hypertensive patients have an almost 2 times increased risk for a severe acute pancreatitis and almost 3 times increased risk for mortality. We investigated diabetes patients also, and diabetes statistically significantly increases the risk for severe AP. However, the correlation between diabetes and mortality is not mathematically proven yet. We did analyze patients who were presented with a borderline elevated triglyceride levels on admission, but who did not meet the criteria of a hypertriglyceridemia-induced acute pancreatitis. And what we saw is that these borderline elevated triglyceride levels statistically significantly increased the risk of both severe acute pancreatitis and even mortality. The strength of our analysis is that this is the first comprehensive meta-analysis in the field, and we analyzed the metabolic syndrome factors individually also. However, there was a high heterogeneity among the studies, and the sample sizes in the subgroups we created are quite low. Our conclusion at this point is that metabolic syndrome and its components individually worsen the outcome of acute pancreatitis and may serve as a clinical predictor for severity and mortality. The implication for practice would be that metabolic syndrome patients require a closer monitoring, and lifestyle counseling and education of obese patients is important. However, the accuracy of other body composition parameters rather than BMI in prognostic scoring and risk assessment is to be further investigated. While I'm still waiting for the rest of the statistical analysis, I have started working on the manuscript, which I have done the methods and most of the results part. Moving on to my second project, we are investigating the effect of these 4 metabolic syndrome factors, but in this case on the outcome of COVID-19. As we all know, COVID-19 was a viral infection with a mortality rate of 3 to 7%, and the clinical spectrum ranges from a symptomatic infection to mild respiratory tract symptoms to even severe pneumonia and multi-organ failure. And it may seem that this pandemic is over, but it is very important to investigate all the data that was available from this last pandemic, because despite the fact that there are huge medical and scientific advances, there is a tendency for diseases to spread and escalate into the pandemic, partly because of urbanization, traveling, climate changes, and even the lack of healthcare workers also. So we are hoping to be more prepared if another pandemic occurs in the future. That is very important to analyze these data. And metabolic syndrome factors were associated as a risk factor in many other diseases. So our aim with this study is to do the first comprehensive analysis on the combined and synergistic effects of metabolic syndrome components on the outcome of the infection. Our question was how metabolic syndrome factors influence the outcome of COVID infection, and we investigated the same 4 exposures as I mentioned earlier, and we would like to see how they affect the need for ICU admission, mechanical ventilation, disease severity, and mortality. And we hypothesized that the more from the 4 metabolic syndrome factors are present, the worse the progression and outcome of the COVID infection will be. And with this study, we are hoping to improve the risk assessment of patients. For this cohort analysis, I will be using the same registry as Luca has already mentioned, that has almost more than 1,000 patients data from 6 Hungarian and 1 Croatian center. For this project, we have set up a preliminary data retrieval plan, and now I'm working on the clean data table. As a summary, I have 2 ongoing projects right now, and both of the manuscripts are to be submitted this year. I would like to close my talk with the words of Abraham Lincoln: "Things may come to those who wait, but only the things left by those who hustle." Thank you for your attention.
What about cholesterol?
In this study, we only investigated serum triglyceride when examining the patients.
Both studies?
Yes.
Why not?
But we can incorporate that into the cohort analysis.
Why is it just always triglycerides and never cholesterol?
Some of the studies report cholesterol levels also, but...
and is that associated with a worse outcome, dose-dependently?
We haven't investigated it, but...
Why not? Bigger fish.
This is a good idea. Thank you very much.
That's that is part of the lipid metabolism.
thank you for your comment.
I have to change my limit of diagnostic limit, or the risk of patient with, say, with a 5.8 triglyceride level of the chance of having acute pancreatitis. You have to change because the level of diagnostic level is much higher at present, and the textbook is around 11.
Yes.
If I'm not mistaken.
In these studies that I presented, cutoff values were between 1.7 to 2.3 millimole per liters, the serum triglyceride level, and we saw
So I
increased
have
risk.
to change
Yes. Yes.
my thinking about
Yes.
that, and the textbook things are not anymore valid. Do you say that?
Yes, this is what our data suggests.
Mhm.